Hello, and welcome to Noon Conferences hosted by MRI Online. In response to the changes happening around the world right now and the shutting down of in-person events, we have decided to provide free daily Noon conferences to all radiologists worldwide. Today, we're joined by Dr. Sheng-Che Hung. He is a clinical assistant professor of radiology at the University of North Carolina, Chapel Hill. He currently serves as the assistant editor in the American Journal of Röntgenology. A reminder that there will be time at the end of this hour for a Q&A session. Please use the Q&A feature to ask all of your questions, and we'll get to as many as we can before our time is up. That being said, thank you so much for joining us today, Dr. Hung. I will let you take it from here.
Okay, thank you for having me here. And today my talk is going to talk about the location-based differential diagnosis of pediatric brain tumors. And the target audience of my lecture, I will be more focused on the general radiologists or some non-neuro specialists who might not be very familiar with pediatric brain imaging, but they still really occasionally need to read those studies. And I hope my talk will be also be very helpful for trainees. The goals of my lecture today, I'm going to talk about. After the lecture, I hope the audience can know how to approach a primary brain tumor in children. And after this lecture, they'll be able to provide a list of reasonable and useful differential diagnosis in the report. In this talk, I will introduce some basic facts about the pediatric brain tumors. I will also talk about the most common tumor types in each compartment of the brain, but I will not talk about the new molecular classifications in 2016. I probably will talk about some, but I will not go into the details because I don't have enough time to cover this one, and I believe there will be a new classification coming out next year. And I will also not go into the detailed features of different tumor types because the internet is your best friend. And if you want to know a specific tumor type, you probably just Google it and you will find much more information. And in this talk, I will also not cover how to differentiate between tumor infection and demyelination, etc. Okay, let's get started. So based on the most recent update, the Central Brain Tumor Registry in the United States, we know that brain tumor is the most common tumor type in the childhood from 0 years old to 14 years old. And besides that, the brain tumor is also the most common cause of cancer death following perinatal conditions, congenital anomalies, or some accidents. But the brain tumor is the most common tumor relating to death in children. Some numbers might be interesting to you, and you probably need to know. Whenever you see a tumor in the pediatric brain, you have a 60% chance the tumor is going to be a malignant tumor. Compared to adults, there's only 30% chance to be a malignant tumor in adults. And when you see a tumor in the pediatric brain, 50% of them will occur in the postural fossa, including the cerebellum, brainstem, and fourth ventricle. Compared to adults, only less than 10% of the brain tumors will occur in the postural fossa. Look at the curve. You can see from the top curve is the gliomas excluding the pilocytic astral, and the second curve is the pilocytic astrocytoma. Both of them are gliomas. So you can see the most common tumor types in children are the gliomas, either malignant glioma or benign gliomas, followed by embryonal tumors, including medulloblastoma or PNET. Both of them are embryonal tumors. So the incidence are highest in the young children, then the incidence goes slowly decrease along with age. Interestingly, there's another curve called pituitary tumor. The incidence in young children is very low, but if you look at the image of adolescents, the pituitary tumor incidence is higher than gliomas. Let's compare the tumor types again. When you look at the tumor in young children, there's a 50% chance the tumor is going to be a gliomas, either pilocytic astrocytoma or malignant gliomas. Then the 30% chances there's going to be embryonal tumors, either medulloblastoma or ATRT or PNET. However, the entity of PNET is no longer existent in the new classification, so you can just focus on the medulloblastoma and the ATRT. Compared to adults, The most common tumor in the brain is meningioma. The intraaxial tumor most commonly is glioblastoma, then followed by the pituitary tumor. So you can see the differential diagnosis is much, much different compared to in children and the adults. The clinical presentations are not very helpful and not specific. The presentation include the patient might have impaired neurological functions, like due to the tumor infiltration, due to the brain parenchyma compression, or due to the increased intracranial pressure, either due to the space occupying lesion or due to hydrocephalus. Or the patient might also have some presentations like macrocrania, seizures, endocrine deficits, or mental intellectual alterations. Those are pretty non-specific. How about the protocols? We know we usually routinely give contrast for kids or for patients with brain tumors, but from the viewpoint of a differential diagnosis, the pre-contrast CT is more important and helpful than post-contrast CT for the differential diagnosis, because the non-contrast CT can give us information about the blood and classification. We can also differentiate between them, which is sometimes very difficult on MRI to differentiate blood and classifications. And we also can give the density of the look at the density of a tumor. High density means high cellularity. Low density means low cellularity, which is also very useful to guide our differential diagnosis. The MRI protocol, based on the recent recommendation from the retinal working group or from the textbook, we recommend you at least should have a T1, T2 weighted image flare and the T1 with contrast, either 2D or 3D. If you are using 2D sequence, we recommend you use thinner slices like less than 4 millimeters. For smaller lesions, you probably need to consider less than 3 millimeters. And in UNC, we also do high resolutions of millimeter volumetric image like KISS or FIESA images. We don't do it routinely, but when we want to look at the cranial nerve or aqueduct stenosis or pineal region tumors, or some extracerebral tumors like epidermoid, dermoid, we also prefer to add the KISS images. And we also routinely use diffusion weight image because we need to look at the tumor cellularity. SWI can provide information about the hemorrhage and the classifications. And post-gadolinium T2 flare, this is very useful for detecting leptomeningeal metastasis. So whenever you look evaluating a tumor, especially high-grade tumor, we recommend you include this sequence as a routine that can help you to detect very subtle seeding. So how can we approach a tumor? The first one is detection, of course. But detecting a tumor is usually not very difficult because you probably see a tumor. The mass is already there, so it's not difficult for us to detect the tumor. Then next step, you need to differentiate this tumor is intraaxial or extraaxial tumor. Then I will further talk about the location-based differential diagnosis. You still think about what's the most common tumor types in this location. You might have some 2 or 3 tumor candidates in your mind. Then we look into the tumor characteristics, like cellularity, like the tumor might have a cyst, a necrosis, or blood calcifications, or the enhancement shows vascularity, or heterogeneous enhancement or no enhancement. These can further narrow our differential diagnosis to bring up the final candidate. So since the gliomas are the most common tumor types in children, we need to know how do we differentiate between the 3 common entities of gliomas, including the low-grade gliomas, grade 2, and the high-grade gliomas like anaplastic astrocytoma or the GBM, grade 3 and grade 4, and the pilocytic astrocytoma, which is a grade 1 tumor. And location-wise, all of them are intraaxial tumors, so location is not very helpful. How about the appearance? The low-grade tumor usually appear as a solid tumor, and the high-grade tumor appear as a complex solid and cystic tumor. And pilocytic also could appear as a solid and cystic tumor. Enhancement, the low-grade tumor usually has no enhancement, and the high-grade tumor can have a minimal enhancement to strong enhancement. the pilocytic astrocytoma almost have an enhancement. 95% of tumor can have an enhancement. The cyst can also be enhanced in 50% of cases, not always enhanced, but sometimes they can be enhanced. So based on the appearance and the enhancement, we can differentiate between low-grade tumor and the other two. But how can we differentiate between the high-grade tumor and the pilocytic? We need a diffusion weighted image, because the diffusion can look at the cellularity. If there's a high-grade tumor, that's usually they will show restricted diffusion on DWI, and the pilocytic will not show restricted diffusion on DWI. So we can use diffusion to differentiate these two entities. Let's move on to the location-based differential diagnosis. In the brain, we usually divide the differential diagnosis into 3 compartments, including the supratentorial compartment and third ventricles and the posterior fossa. Since the posterior and also the atrial space, like atrial space, but I will not cover this part today. Since the posterior fossa is the most important space of a pediatric brain tumor, so let's move on this first. And you can further divide the posterior fossa into 3 regions, including the brainstem, cerebellum, and the fourth ventricle. In the brainstem, from top to bottom, whenever you see a tumor in the midbrain, the most common tumor types is low-grade tumor, either pilocytic astrocytoma or other grade 2 low-grade gliomas. The tumor appearance will appear intrinsic, and since we are very close to the aqueduct, so the patient might present early aqueductal stenosis and hydrocephalus. Even the tumor is very small, so you need to look very carefully in the midbrain, especially the periaqueductal region, to look for very subtle signal changes. This is the case. You can look at this one, the sagittal flare. We can see abnormal signal in the tectum and the probably periaqueductal region. There's no enhancement, and the diffusion adhesion map shows no restricted diffusion. So we know this is a low-grade tumor. And since there's a special entity of a low-grade tumor in the midbrain, they will involve the tectum. So we have given him another term. It's called the tectoglioma. The tectoglioma, their genetic profiles and genetic mutation are different from the low-grade tumor in other region, like a supratentorial region or cerebellum. So that's why the natural cause is also different. The midbrain tectal tumor is the second common place of tumors in the brainstem. And the tumor types, the most common one is the pilocytic astrocytoma, followed by grade 2 low-grade tumors. This case shown here is a grade 2 tumor. And the tumor in the midbrain could be enhancing or non-enhancing. And they usually tend to present with early and chronic hydrocephalus. Since the tumor is generally very slow growing and very indolent, so current recommendations, whenever you see this tumor, the surgeon will be not very hesitate, will not be kind of directly going to get some tissue proof or get any tissues. They probably just will treat the patient with CSF diversion like shunting or third ventricular stomy. However, we do see some midbrain tumor can be progressive and metastasize. So you can see this is another case. These are large midbrain tumors with enhancement, with heterogeneous enhancement, and instead involved in either the ventral midbrain and dorsal midbrain. Do we have any parameters can predict the tumor progression in the initial diagnosis? There are currently some parameters which is known can predict the tumor progression. The first one is the size. If you see a midbrain tumor is larger than 3 square centimeter, we use across any area to measure the size. Or if you see a tumor is a contrast, there is a contrast enhancement, or you see a tumor with a CC change, these parameters might suggest the tumor might have a higher chance to progress in the future. So you can put this in your report to remind the surgeon to keep attention on follow-up. So let's move on the pons. The pons, we divide the pons into the ventral pons and the dorsal pons. The dorsal pons, the most common tumor is also a low-grade tumor, the pilocytic astrocytoma. The tumor here will appear like a dorsally esophageal tumor, and since it's a pilocytic astro, so they might appear as a complex solid cyst tumor, just like this one. This axial flare, you can see the tumor involving the ventral pons and dorsal pons. And the ADC map shows no restricted diffusion, probably slightly, but most of the tumor did not show any restricted diffusion. On the sagittal view, you can see the epicenter of the tumor is in the dorsal pons and the posterior dorsally esophageal with some cystic changes. And so this turned out to be a pilocytic astrocytoma. So just remember, even the tumor looks very aggressive and very high grade looking, but just look at the diffusion map. If there's no restricted diffusion, they can give you suggest this is probably just a pilocytic astro. Going to the ventral pons. The ventral pons, the most common tumor is the DIPG, diffuse intrinsic pontine glioma. Different from dorsal pontine tumor, the ventral pontine tumor, they will show the ventrally esophageal. They also can appear solid and cystic appearance. So you can see this tumor epicenter in the ventral pons with some ventral esophageal, and even surrounds the basal artery to engulf the basal artery. Then, if you remember, the midbrain is the second common site of a brainstem tumor. So the ventral pons is the most common brainstem tumor site, and it's the most DIPG is a high-grade tumor, and 80% of the tumor have a mutation H3K27M mutant. This has been mentioned in the new classification, but I will not go into the details about this. And usually the DIPG have a very poor prognosis. The time to progression is less than 6 months, and overall survival in 2 years is less than 10%. However, you need to remember one thing: DIPG is a clinical radiographical and defined entity. That means if you see a tumor that fits the typical appearance of a DIPG, the surgeon probably will not go in to give tissue biopsy because they have carry a high risk. So they probably just directly go to treatment. Then you need to know what's the typical appearance of a DIPG. The typical appearance of a DIPG, we include that you should make sure the tumor center is in the ventral pons, and the tumor involved more than 2/3 of the cross-sectional area of the pons. And you see the tumor has a ventral esophagism. And the tumor might have some intralesional inhomogeneity, including enhancement. And based on these criteria, we can have a very high accuracy to diagnose DIPG. However, if you see a tumor which doesn't fit the typical appearance of a DIPG, that means the surgeon might need to go in to get tissue biopsy. For example, if you see a tumor in the pons, but it's not a center in the ventral pons, like in our prior discussion, you might see the tumor in the dorsal pons, or the tumor is not in the center. It could be eccentric location, or they shows unusual extrapontine extensions, or you see a tumor has dorsal esophagism, not ventral esophagism, or you see a tumor which is smaller, less than 50% of the cross-sectional area of the pons, or the margin is too well defined, or you see too much enhancement. This means that the pontine tumor is not typical of a DIPG, so you should recommend in your report to suggest a surgeon might need to get a tissue biopsy. However, even you know this, the surgeon go into, we still probably could be wrong. Still 50% of them are still DIPG, but that means we have another 50% of tumors which are not DIPG, which might change the treatment strategy. And this another tumor, you can see the tumor is T1 hypointensity, and the center is in the dorsal pons, not a ventral pons. And the tumor is very small, less than 50% of cross-sectional areas. And we perform from the textbook, the MRS show no increased calling. So this is a focal pontine tumors. The focal means is in contrast to the diffuse. Focal means the less than cross-sectional area of 50%. And usually this means low-grade tumors. It could be pilocytic astro, or could be grade 2 tumors, not DIPG. And let's move on to the middle cerebellar peduncle. Middle cerebellar peduncle, the most common tumor, again, is pilocytic astrocytoma. The tumor here, you can see a well demarcated tumor, might have some cystic appearance. For example, this case, we see a tumor on the left side, middle cerebellar peduncle, like a slightly expansile appearance, T1 hypointense, shows a lot of enhancement, well demarcated. But the most importantly, there's no retreat diffusion. So this turned out to be a pilocytic astrocytoma. Sometimes you might see extend along the cranial nerves. And let's move down to another location, cervical medullary junction. The cervical medullary junction, again, the most common tumor types is the low-grade tumors. 84% are low-grade, either pilocytic astro, and one interesting tumor, one is different tumor, is ganglion glioma. So when you looking at the tumor in this location, you should think about pilocytic or ganglion gliomas. The difference between them is pilocytic astrocytoma tend to be more esophagic, more solid and cystic, and ganglion glioma might be more intrinsic. They might have some expansile appearance, but not esophagic to the CSF space. Look at this case. This is a 2-year-old boy with 2 months history of left side hemiparesis. We see a cervical medullary tumor, like esophagic to the dorsal CSF space, and high-grade looking, but this turned out to be the pilocytic astrocytoma. And this is another case. You can see that in the cervical medullary junction, there's a complex solid cystic tumor, and there's also a large cyst protruding into the fourth ventricles. You can see the flare here. That means they can demonstrate the different signal intensity between the CSF and the cystic portion. And most importantly, there's no retreat diffusion. This again is a pilocytic astrocytoma, not a high-grade tumor. How about this one? This is a 5-year-old boy with hypotonia. So we again see a tumor centered in the cervical medullary junction, slightly expansile appearance, no obvious cystic appearance. But interestingly, in the pilocytic astrocytoma, usually the solid portion will show strong enhancement. But in this case, not all the solid portion is enhanced. You can see kind of a patchy enhancement, even enhanced on the dorsal surface. And again, there's no retreat diffusion. So you know this case is a ganglion glioma. The ganglion glioma tend to occur in the cervical medullary junction, could be infiltrative, could be expansile appearance. And one important thing is their enhancement is kind of a patchy, we call the paintbrush enhancement. And it's a low-grade tumor, but this tumor has a higher risk of CSF spread than pilocytic astrocytoma. So you should keep this in mind, look at the spine or recommend spine images. So this is another case. You can see kind of expansile appearance. If you look at the T2, the size, the boundary of the tumor is larger than the enhancing portion. So not all the solid portion is enhanced, kind of a patchy enhancement. So this again is a ganglioma. Let's move on to cerebellum. The cerebellum, whenever you see an intraaxial tumor, the most common differential again is gliomas, like either pilocytic astrocytoma or other low-grade, high-grade tumors. And remember our guideline to how to differentiate both of those tumors using the enhancement, using the diffusion. You will be able to differentiate those gliomas. Another differential diagnosis you need to keep in mind is medulloblastoma. There's a specific type we call the sonic hedgehog type. They also tend to occur in the intraaxial location of cerebellum. And how do we differentiate this one and the pilocytic astro? The medulloblastoma, they tend to have a 90% enhancement, and importantly, they will show retreat diffusion on theta pi. So this can help you to guide the differentiation between the pilocytic astro. For example, in this case, we see a complex solid and cystic tumor in the cerebellum. And you can see the fourth ventricle is compressed and no retreat diffusion. The solid part shows very good enhancement. So this is a pilocytic astral. The diffusion is very helpful to differentiate between the low-grade tumor and the high-grade tumor. But the perfusion or the MRS might not be very helpful because the pilocytic can also, the solid part can also show increased blood volume, also increased clotting. So might not be able to differentiate between the pilocytic and the high-grade tumors. And again, the diffusion is no restrict diffusion, which is very helpful. How about this one? And we see a CC tumor in the cerebellum, but we see a solid portion enhancement and a no restrict diffusion. Even the solid part shows no restrict diffusion. And but one important thing is today's topic is talking about the pediatric brain tumors. Look at the age. The case is too old. It's 35 years old, so it should not be a pilocytic. Usually should not be. And so this is a hemangioblastoma. Hemangioblastoma is tend to occur in the young adults between 30 to 60 years old, but it could happen in children, especially in patients with von Hippel-Lindau syndrome. So whenever you see a case in the cerebellum, you need to pay attention to this differential diagnosis. How can we differentiate hemangio from the pilocytic? Usually the hemangioblastoma, the solid portion might have a very strong enhancement, and their cystic wall is not enhanced. We know pilocytic, they have 50% to be enhanced, but the hemangio, usually the cystic wall is not enhanced. And another important thing is the enhancing nodules about the surface of pile surface, and you might see engorged vessels surrounding the enhancing nodule. So these are the clues for the hemangioblastoma. Okay, let's move into the fourth ventricles. This probably all of you are already very familiar. If you see a tumor arising from the roof of the fourth ventricle, means the posterior wall of the fourth ventricle, the differential should include a medulloblastoma. The typical appearance is ventrally growth from vermis or the intraventricular tumor, or you might see restricted diffusion due to the high cellularity. This is the typical appearance. The CT shows high density, means high cellularity tumor, and TY hypointense, and the post-contrast may have a strong enhancement, may have a minimal enhancement, depends on different types of medulloblastoma. But important thing is it shows a restricted diffusion, so this is a medulloblastoma, and this is the most common placebo-facile tumor in children. And typical location arising from the vermis and grows into the fourth ventricle. The CT show hyperdense because the high cellularity, MRI show restricted diffusion. And although I said I don't want to bring out the molecular classification, but there's still something you need to know. Currently, we have 4 molecular subtypes in the new WHO classifications, like Winley's type, Sonic Hedgehog type, Group 3 and Group 4. I don't want to go to the details, but you probably need to know even the medulloblastoma, the different types might have a different location preference. Like Winley's type, the Winley's type might stay in the central, but they also like to extend laterally to the CP angle. So whenever you see a tumor looks like a medulloblastoma but extend to the off midline, it could be the Winley's type. And Sonic Hedgehog type, I already mentioned, they like to be intra-axial location, the show restricted diffusion and heterogeneous enhancement. And group 3 and group 4 are more in the typical midline location. And the group 3 shows strong enhancement, and group 4 usually has no enhancement. So this is probably something you need to know. And this is a companion case. Again, we see a very large tumor, probably in the vermis, but you can see that the fourth ventricle is compressed rather than expanded. So that means the epicenter almost the whole tumor is in the vermis, not in the fourth ventricle. Shows strong enhancement, again, no restrict diffusion. So what's the diagnosis? It's again a pilocytic astrocytoma. So you need to pay attention to the location of the tumor, epicenter of the tumor. So it might be helpful to differentiate these two. Okay, let's move on to the floor. The fourth ventricle floor means the anterior wall or the inferior aspect of the fourth ventricle. The most common tumor here is ependymoma. And the characteristic findings that you need to know is ependymoma usually very heterogeneous. Heterogeneous means they not only the enhancement is very heterogeneous, they also carry some blood and also tend to calcify, which are not common to be seen in the pilocytic or medulloblastoma. So whenever you see a tumor with bleeds or calcifications, and in the ventricles, you should think about the ependymoma. And another interesting appearance is the tumor tend to insinuate into the cisterna magna or CP angle into the CSF space or through other foramina. So you can see a case here. We see a very, very heterogeneous tumor and also have some blood here. And so this case is an anaplastic ependymoma. Sorry. So let's move on to the hemispheres. I'm sorry. We divide the region into three groups. One is the central gray matrix or Y matrix or the cortex. The central gray matrix means the basal ganglia and the thalamus. Whenever you see a tumor here, the most common one, again, are gliomas. Could be low-grade tumor, could be high-grade tumors. And just remember using the contrast enhancement and the diffusion to differentiate those groups. And remember one thing, whenever you see a high-grade tumor looking mass in the basal ganglion, always think about the diffuse midnight glioma carrying the H3K27M mutant, which is also a new classification in the WHO. And that just means the tumor might have maybe a more aggressive and involved in the midnight, including the brainstem and the basal ganglion, and the brainstem basal ganglion, yes. So this 9-year-old boy with abnormal gait, we see a very heterogeneous tumor centered in the right basal ganglion. See heterogeneous enhancement, and look at the T2, some necrotic change, but some solid portion, and show restrict diffusion, but no enhancement, non-enhancing part. So that means this is a high-grade tumor, not pilocytic astral. So this is turned out to be anaplastic astrocytoma. Could be IDH Y type, and this case carrier H3K27M mutant. And this is another case. We see abnormal signal involving bilateral thalami, especially in the right thalamus. It's cross the midline to the left side. There's no enhancement and probably slightly reduced diffusion, but not much. And again, this is a diffuse astrocytoma, but this one doesn't carry the mutation. So let's move on to the Y matter. Y matter again, sorry about that, but the glioma always should be your differential diagnosis because 50% of the pediatric tumor are gliomas. But there's another tumor you might need to keep in mind is ependymoma here. Ependymoma in the posterior fossa, they will occur in the fourth ventricles, but in the supratentorial regions, they usually in the parenchyma. And again, their typical appearance is very heterogeneous. That means the tumor might have a solid and cystic portion and might have also calcification or some hemorrhage. For example, you can look at this one, 3-year-old boy with drowsiness, and you see a very, very large tumors and the cystic portion, also carry some calcifications and some solid portions here. And this solid portion shows restrict diffusion. That means it could be high-grade tumors, but it's weird to have some cystic portion and calcification for the GBM for the gliomas. And besides, you can see the tumor should be in the Y mater or periventricular region and protruding into the ventricles rather than in the ventricle protruding outside. So this is anaplastic ependymoma. And remember, again, supratentorial ependymoma, it accounts as 30% ependymoma. And one thing you need to know is the supratentorial ependymoma usually carry this gene, the RELA fusion positive subtype, which is also a new classification. And the ependymoma have a coarse calcification in 50% of tumors, and 50% of the tumors might have a CC change, might have a hemorrhage, and the diffusion depends on the grade. It could be low grade, could be high grade, so have a different appearance on DFI. Okay, let's move on to cortical tumor, the peripheral gray matter tumor. And usually the keys will come for study in this group is for the epilepsy, because the cortical tumor, they might might present with seizure early in the course, and so you need to remember what's the most common type in this group of patients. Depends on the location. If they see a cortical tumor in the temporal lobe and the patient present with chronic seizures, this is the top differential diagnosis you should think about. It's ganglion glioma, and the ganglion glioma here, they kind of have various appearance. They can maybe solid, they can be cystic, or can be infiltrated, and sometimes can have a calcification. So it's not very specific finding. There's no specific finding. Outside the temporal lobe, whenever you see a cortical tumor in kids with chronic seizures, think about the DNAT or think about the pleomorphic zenso astrocytoma. And in adults, there's another tumor, it's oligodendroglioma, by which is uncommon in children. So that's why I did not put it here. And look at this case, the patient with a chronic seizure, and we see a right side parietal tumor, like a bubbly appearance, a pyramidal shape going from the cortex to the subcortical Y matrix. And typically, this tumor shows no enhancement, usually no restrictive fusion. Another thing is the central part of the tumor will usually be suppressed by flare, but the ring will not be suppressed. So we will see the bright ring, which is a very interesting appearance of a DNAT. So this case is a DNAT. And another case again, the patient coming with a chronic seizures, we see a temporal lobe cortical tumor, and looks solid and there's very good enhancement. But if you remember the appearance of a cervical medullary ganglion glioma, that means not all the solid portion is enhanced, it's kind of a patchy heterogeneous enhancement. So this again is a ganglion glioma. Okay, let's move on to the third ventricle, which is also complicated, but I will not spend too much time in this because they will be out of scope of this lecture. The third ventricle, the first one, if you see a tumor in the anterior third ventricle, you should look at the optic nerve and optic pathway. If you see a tumor arising or involved optic pathway, you should think about the pilocytic astrocytoma. Another differential is pilomysoid astrocytoma. And usually the tumor in this location is associated with neurofibromatosis type 1. And this tumor could be intrinsic and usually solid, but pilocytic can also have some cystic appearance. So you can see this tumor, if you see a tumor involved third ventricle, also the optic pathway, so you should think about pilocytic astrocytoma in this group. But if you see a tumor like very, very bright on T2, almost look like the cyst, but this cyst shows enhancement. That means this is not a truly cyst, just very T2 hyperintense solid part. They might reflect the patient, the tumor have a myxoid appear component. So they could be suggest you to think about the differential of pilomyxoid astro. And optic pathway is commonly in young children, and based on some series from Japan, the optic pathway tumor, the most common one is still again the pilocytic astro, but the second type is followed by the pilomyxoid astrocytoma. And how do we differentiate these two? As I said, if you found some T2 very, very hyperintense in the solid part, could be suggested could be the pilomyxoid astrocytoma. And besides, the pilomyxoid astrocytoma can be more aggressive and could be disseminated easier than the pilocytic astro. And either one, usually in this location, the total resection is almost impossible. So the surgeon or the oncologist might tend to use chemo and the radiotherapy to treat this group. And the suprasellar tumor, also the differential you probably already know. It should include the craniopharyngioma and the germ cell tumor and the pituitary tumor. Depends on the age, especially in the adolescence. I already said pituitary tumor has a very has higher incidence than other tumors than in the adolescent group. And how do we differentiate this? And I will not spend too much time talking about this. If you are interested, there's a very good article a few years ago in AGNR that they show you how to differentiate with craniopharyngioma and the germ cell tumor in the suprasellar region. So if you are interested, you can look at this article. And they also have some very good graph to teach you how to differentiate these. Okay, let's move on to the hypothalamus. And the hypothalamus, again, is an intraaxial tumor. So the two things you need to differentiate. One is craniopharyngioma and or pilocity astral. And how do we differentiate these two? Usually these two have a short no restrict diffusion, so we probably just based on the epicenter of the tumor and based on the appearance. The cranial, they tend to more be complex solid and cyst and tend to have more calcifications. Pilocity usually have no calcifications, and the pilocity should be more centered in the hypothalamus, and the cranial should be centered more in the ventricles or suprasellar regions. So probably those are the clues to differentiate these two. And then move back to the posterior part of the third ventricle. And posterior part of the ventricles, if you see a tumor coming from the thalamus, the lateral wall, again, you should think about pilocity, astrocytoma, or high-grade tumors. Again, depends on the image appearance. And one clue is you need to look at the pineal gland to see this tumor coming from within the pineal gland or displaced the pineal gland. They can help you to differentiate. For example, this is an extreme case. You can see the tumor is more centered in the thalamus, but extend to the pineal region and the posterior part of the ventricles. So might cause early hydrocephalus because due to the aqueduct involvement. So this tumor is a diffuse midline glioma because you show some enhancement here and probably some restrict diffusion here. So it means there's a high-grade tumors, and so this is a diffuse midline glioma. And if we see a pineal tumor, and the pineal tumor, the most common two entities you need to think about is the germ cell tumors and the pineal blastoma. I will not go into the details to tell you what's the image appearance of each type of germ cell tumors or pineal blastoma. And sometimes I also have a difficulty to differentiate between germ cell tumors and pineal blastomas. There's one clue being brought up in the textbook by Professor Bakovich and the Rabo. They say if you look at the FLAIR images of the tumors, the pineal blastoma tend to be more iso-intense compared to the surrounding structures. But the germ cell tumor on the FLAIR, they tend to be more hyper-intense compared to surrounding structures. I don't have such experience using this one, so probably you can keep this in mind in the future whenever you see pineal tumors and you are thinking about these two entities, you can use FLAIR to try to narrow in your differential diagnosis. But how about this one? Again, we see a solid, complex, solid CC tumor, only part of the enhancement, but importantly, you see there's no restrict diffusion. And if you look at the sagittal view, you can see the tumor even goes down to the midbrain, the tecton areas, and the pineal gland is displaced upwards. So this is not a pineal tumor. This turned out to be a pilocystic astrocytoma. We believe probably comes from the tecton midbrain. And the third ventricle, in the lateral part of the ventricle, there are 2 or 3 tumors you probably need to know, like a pterochoroidea arising from the choroid plexus, or arising from foramen Monro, like SEGA. You're already familiar with this group. I don't need to talk too much about this. But one thing probably you need to know is using the coronal view to make sure the relationship between this tumor and the choroid plexus. If the tumor is connected with the choroid plexus, it's likely it could be a choroid plexus carcinoma, papilloma. If it's not, if the patient have a tuberous sclerosis history, should be thinking about the SEGA. So this is a choroid plexus tumor, and this one looks similar to a popular choroid plexus tumor, but this one's far away from the choroid plexus. So this one is a SEGA, not a choroid plexus tumor. And probably this is a few last slides I'm going to talk about. If you remember, the most common tumors in the pediatric brain include the gliomas and the medulloblastoma, the NTRT, but during my talk, I never brought up how to differentiate, how to think about ATRT. Because ATRT, although it's a second common embryonal tumors, and you probably need to know is that usually occur in the very, very young children, like less than 3 years old, and the incidence drop dramatically after 3 years old. Although we see some cases in the older children, but usually this tumor occurred in the less than 3 years old. And the distribution of the tumors kind of was equally between the infratentorial and supratentorial, although it tends slightly more to involve infratentorial region, but the incidents are very similar. Sometimes they also involve both supra and the infratentorial. And the image findings, they are very, very heterogeneous enhancement, or sometimes with cyst and hemorrhage, and they tend to have an early leptomeningeal spread in 15% to 20% of the cases. So when do we need to think about ATRT? So just remember this: when you see a young children, less than 3 years old, you see a very high cellular tumor, you should think about ATRT, especially if the tumor shows a large heterogeneous enhancement and the CT shows high density, means high cellularity, data shows rich diffusion. When you start to think about medulloblastoma, that means at this stage you already need to think about ATRT. And as I said, the tumor tends to have some leptomeningeal enhancement, also involve the cranial nerve. So if you infant present with a cranial nerve palsy or some CSF space tumor, you also need to think about ATRT. This is one case. You see a mesial temporal tumor, CT shows high density, means high cellularity, diffusion shows rich diffusion. And I did not show the enhancement of the tumor. You believe me, it shows heterogeneous strong enhancement. But I want to show here is you can see some leptomeningeal enhancement even along the cranial nerve 3. And the spine image also shows some spinal seeding. So this is an ATRT case. Okay, let's go through review again. In the brain, we divide into the supratentorial part, compartment, third ventricle, and the posterior fossa, and the extraparenchymal space. When you think about the hemispheres, usually we divide into the central gray matter, white matter, and the cortex. In the central gray matter, think about gliomas, either high grade or low grade. And the thing about the diffuse midline glioma, if it's a high grade tumors. White matter lesions, think about gliomas again. But if you see a large heterogeneous cystic tumor with calcification, think about ependymoma. Cortical tumors, when the patient presents with seizure, epilepsy. In the temporal lobe, think about ganglion gliomas. In any locations, think about the DNAT and the pleomorphic zenso astrocytomas. In the subventricles, how about subventricles? In RD pathway, think about pilocytic astrocytoma. If it is a T2 hyperintense, think about pilomesoid astrocytoma. Supracellular region, think about craniopharyngioma, germ cell tumor, pituitary tumor. And if the tumor is in the posterior third ventricle, coming from the thalamus or coming from the midbrain, think about pilocytic astrocytoma or other high-grade tumors. If the tumor is centered in the pineal gland, think about the germ cell tumor and the pineoblastoma flare. Sometimes can be helpful to differentiate these two. And in the lateral part of the ventricles, just look at the choroid plexus and the tumor. And if the tumor is connected to the choroid plexus, think about the choroid plexus papilloma or carcinoma. Or if the patient have a tuberous sclerosis history, think about the SEGA. The posterior fossa, in the midbrain, think about low-grade tumor like a pilocytic astro, and dorsal pons, think about pilocytic astro again. Ventral pons, think about DIPG, but remember those typical appearance of a DIPG. If the image appearance is not typical, probably you need to suggest biopsy. In the middle cerebellar peduncle tumor, pilocytic astrocytoma again. Cervical medullary junction, think about pilocytic again, could be more esophagic and could be solid the CT portion. But if you see a pendiporage, expansile solid tumor, think about ganglion glioma. Cerebellum, think about gliomas again. And medulloblastoma, if you see a high-grade tumors, think about this one. And in the fourth ventricle roof, think about the medulloblastoma. The floor, think about ependymoma. Ependymoma tend to more heterogeneous with blood and the calcification insinuate into the cisterna magna and the foramina. And remember this table, which is very important and probably easy for you to remember, using the diffusion to differentiate with high-grade tumor and the pilocytic. Summary, location-based approach can help us to bring up the most common 2 or 3 types of tumors in each location. Then use diffusion, weight image, and gadolinium and try to differentiate these two can narrow your differential diagnosis. And think about ATRT when you see a high cellularity tumor in young children, either in either location, supratentorial or infratentorial, just see a high-grade tumor. Think about ATRT. That's it. Thank you very much.
Perfect. Thank you so much. I do see a couple questions in the Q&A feature for you if you have a few minutes to answer those.
Okay. Let me see how to bring up.
It'll be if you move your mouse to the top of your screen where it says you're sharing your screen, there should be some icons.
Oh, yeah. I'm looking at the button, so that's why I cannot find it. So how to differentiate, the first one, how to differentiate medulloblastoma and the ATRT from the vermis. And that's a good question, and probably a tough question. As I said, look at the age. If the patient has a young age, like less than 3 years old, and also have in stand to the CP angle or other space, also have some CSF CD, you should think about ATRT. But I admit, I confess, sometimes it's very difficult. Yeah. And can we see ATRT in punks? I remember I saw 1 or 2 cases, but I don't remember the real incidents about ATRT in the punks. But I did see 1 or 2 cases. Yes. And any incidents of intraventricular hemangioma? I'm not sure which kind of hemangioma you're talking about. You mean the cavernous malformation? We do see some, but it's not a common one. So in the goal of this lecture, I'm not going to talk about all the details about every pathology, but I do see some cavernous malformation or cavernoma in the ventricles, but which is not common. And how to differentiate ATRT from rhabdomyosarcoma? Oh, that's a good question. And rhabdo, based on my prior experience, rhabdo usually you should see some like scalp-based involvement or the dural involvement or the skull bone involvement. I never see a case of a purely intracranial, intraaxial rhabdo. So that's what I thought. If you see some sign or some hint of like intracranial involvement, I would think about rhabdo. And thank you for that amazing lecture. Is there any image clue for differential supratentorial ependymoma and the ATRT? As I said, ependymoma tend to have more calcification than hemorrhage, and the ATRT use, and the ependymoma usually have in the white matter, and less commonly to have a CSF spread. But ATRT you tend to highly more likely to have CSF spread and show high-grade tumors. That's what I thought. But I believe if you see some calcifications, that would be very important hint to differentiate the ependymoma and ATRT. And what's common tumor of fatal brain? That's a good question. I don't know. I confess, I apologize for this question. The kids have a brain metastasis, current incidence. Of course, the kids can have a brain metastasis like neuroblastoma, could be something else, but the incidence is lower. So, of course, but I don't have the incidence in my hand, so I cannot give you the answer about this one. And how to differentiate ganglion glioma and the DNAT in temporal lobe. DNAT, as I said, DNAT usually it's you will see bubbly appearance and T2 very bright. The flare might suppress the center part. The bright flaring depends on the size, but the ganglion glioma, in my experience, I see a lot of ganglioma in epilepsy patients. They might have a different types, different image appearance. One type of ganglioma, they may appear solid, and as I showed in my lecture, they can have some enhancement and they could be solid, but it's not a T2 very bright like a DNAT, so it will be easy to differentiate these two. And another group of ganglioma I saw, they will be like infiltrate along the cortex and my minimal enhancement. Sometimes they even carry some calcifications. So your differential should be include like a low-grade glioma rather than DNAT. In my experience, DNAT should be very easy to differentiate between the ganglioma and the DNAT, but sometimes it's difficult to differentiate ganglioma and the low-grade astrocytoma in epilepsy patients. That's it. That's all the questions.
Perfect. Thank you so much. To bring this to a close, I just wanted to thank you, Dr. Hung, for your time today, and thanks to all of you for participating in this noon conference. A reminder that it will be made available on demand at MRI Online. In addition to all previous noon conferences, these are made available complimentary. And tomorrow, please join us for a noon conference with Dr. Daniel Margolis on prostate MRI post-treatment imaging. Thank you so much, and have a wonderful day.
Okay, thank you. Bye.